Good morning, folks, and thanks for joining us today. My name is Dan Griffiths, and I'm the director at the Game and Sexual Health Alliance. Today's webinar comes as we prepare to launch getprimed.ca and the release of Primed, a sexual health guide for queer trans men, trans masculine, and non-binary people. First launched in 2008 by the Trans Men's Working Group, further updated in 2015, this third iteration of the guide was developed by a trans-led project team and sponsored by the GMSH. It includes culturally relevant and evidence-based information on sexual and reproductive health, HIV, sexually transmitted infections, combination prevention, harm reduction, and more. Primed also provides community-developed tips related to finding sex and cruising, consent, and healthy relationships. We're really excited for the launch of getprimed.ca. It'll be a hub for information, resources, and community-generated content on a range of topics that are important to queer, trans, and non-binary people. So we can't wait to share it with you, so stay tuned for details on our virtual launch, which will feature artists, community influencers, and thought leaders. So today's webinar follows recommendations from our Primed project team on areas that the GMSH could strengthen its work, given our mandate to produce sexual health resources and to increase the capacity within our provincial alliance to provide culturally relevant and tailored sexual health promotion services. And so we hope that you find this webinar informative and useful in the work that you do. And I want to thank Dr. Jordan Goodridge for taking the time to share his expertise today, to our moderator, Eric, Manager of Health Promotion at the GMSH, for his work in preparing today's webinar, along with Robbie Ahmed and Christopher at the GMSH office. And so thanks again for joining. And with that, I will hand things over to Eric.
Thanks, Dane. Good morning, everyone. Again, welcome to today's webinar. I hope you're all doing well, and I'm happy that you have taken the time to join us. Everyone will be kept muted throughout the presentation, and I kindly ask that you can give your questions. You will get a little bit of background how we're going to facilitate the Q&A today. I'll begin by presenting a little overview of the agenda, followed by a land acknowledgement, then a bit of a housekeeping. Then I'll introduce the presenter, Dr. Jordan Goodridge, and the presentation, following which we'll have the closeout. So I'm going to start with the land acknowledgement. As we move into today's presentation, I'm taking this opportunity to ground the meeting by acknowledging the land on which we live, work, study, enjoy social and recreational privileges. That we know that this land is Indigenous land, and Indigenous people have rights to this land. It's the traditional territory of many nations, which includes the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. By acknowledging this land, it represents an act of resistance against the continued erasure of Indigenous peoples and their rights. It demonstrates our relationship with the land and the continuous process of colonization that deeply impacts activist work, and it further recognizes that treaties were made, some were broken, and some were never made. Rights were stripped and denied by centuries of laws and policies. As we are aware, COVID-19 continued to exacerbate structural inequities for marginalized communities everywhere, and many Indigenous communities will be far more gravely impacted by these inequities, thus making them more vulnerable, especially those further north and on reserves. So I encourage you to focus our thoughts and actions on mitigating the impact of this pandemic on Indigenous peoples and their communities. Finally, I encourage you to join us at the GMSH with our commitment to learning about Indigenous peoples, their history and culture. Collectively, let's seek out ways to ground our work in decolonizing approaches and practices that will strengthen our efforts to respond to the 94 calls to action issued by the Truth and Reconciliation Commission and stand in solidarity with Indigenous people. So now a little bit of housekeeping. So I'll turn it over to Chris. Please welcome Chris.
Good morning, everyone. So as Eric had mentioned, everyone is muted. So we ask that for any questions that you have, that you use the Q&A feature. It's just a matter of clicking on the Q&A icon within Zoom. A window will pop up and you just need to type your question where it says type your question here. Once you press your enter key, it will submit the question to us and we will then pass that on to Dr. Goodridge. Please note that, that this session is being recorded and it will be made available on YouTube later today or tomorrow. If you encounter any issues at all, please contact me at 416-364-4555, extension 300, and I would be happy to assist you with any technical issues that you may be experiencing. Thank you so much.
Okay, thanks, Chris. I'll give a little bit of background, but while I do so, to maximize use of the time, we'll have Dr. Goodridge's bio up on the screen. We also circulated it in the invite. In our commitment to reach and engage gay, bi, trans, queer trans men, excuse me. In our commitment to reach and engage queer trans men who are part of our communities and sexual cultures, this webinar preempts the work and the upcoming virtual launch of Primed, as Dane said earlier, a sexual health resource for GBQ trans men. We hope that this resource bridges the knowledge gap. As for us cis service providers, we don't always have the right knowledge to best serve GBQ trans men in our sexual health promotion services and provide culturally relevant care and support. So to be intentional about learning and applying best practices around their sexual health, we have with us today Dr. Jordan Goodridge, who will be leading an interactive case-based webinar that discusses key topics to include unique sexual health consideration for GBQT trans men, anatomical and physiological considerations, examples like testosterone effect on sexual health, surgical considerations, STBBI information and testing recommendations, HIV pre-exposure prophylaxis, PrEP and PEP. So without further ado, it's with great pleasure that I welcome Dr. Jordan Goodridge.
Great, thank you so much. I'll just load up my slides here. So I want to say thank you for letting me give this presentation. As stated before, my name is Dr. Jordan Goodridge. I use he, him pronouns and work at the Sherborne Health Center. So I'm really happy to give this presentation for a population that unfortunately is quite often underserved. And so I'd also like to thank everyone for taking the time out of their busy schedules and to learn about important topics with this population. Ideally, this session would be as interactive as possible. Of course, there are some limitations with our virtual platform, but please do use the Q&A feature as previously discussed as we talk about cases throughout. So thank you. You can also ask questions as we go, and I'll try to answer them. Eric will keep an eye on the window so that we see as anything comes up. So in terms of any conflicts of interest or disclosures, really my only disclosures here was that I was a medical reviewer for the upcoming Primed manual, which I encourage everyone to take a look at when it's ready. Through the Gay Men's Sexual Health Alliance. I've given presentations on trans health through Rainbow Health Ontario, as well as CAMH's ECHO program. Rainbow Health Ontario, I will discuss some resources from them today, so I wanted to identify that. Also that I'm a family physician at the Sherborne Health Center, which has produced some guidelines around providing health to the trans population, both trans masculine and trans feminine clients. And so I wanted to just give a little bit of a roadmap for today's webinar. Of course, the field of sexual health is vast, and really any one of these topics could have its own presentation or webinar about them. So I want to touch on how some of these topics specifically pertain to transmasculine clients who have sex with men. And so that includes those who identify as trans men, those who are non-binary but assigned female at birth, and other transmasculine groups. So I'll give a brief overview of sexual health in this population, discuss the concepts of preparing for sex, the effects of testosterone on the body, surgeries, contraception, sexually transmitted infections, HIV, including preventive options such as PrEP and PEP, and online resources that can really be useful for further reading, either for yourself or clients with whom you work, because there's a lot more information out there than will be just provided in this presentation. But I also do want to leave some time to answer questions that people have about things that maybe they've come across or thought about in their own line of work or personal lives. So I really like this image, and a number of you may have already come across this, the gender-bred person. And this I use to kind of talk about some important terminology. To some of you, these terms may kind of feel known or intuitive, but it's important to actually differentiate these concepts. So gender identity, how an individual identifies or defines their gender. Gender expression, which is the ways in which a person presents their gender through their actions, their dress, their demeanor, or other routes. The term biological sex is generally meant to describe the physical sex characteristics, including genitalia, that an individual is born with and develops around the time of puberty. And then, of course, an individual's attraction, sexual and romantic, for instance. So it's important to think about these as distinct entities, each of them which fall along a little bit of their own spectrum. And it's important to think about them separately and not make assumptions on a person if you know one characteristic or another. So for instance, you can't say based on an individual's gender identity about who they're sexually attracted to. How they express their gender doesn't necessarily tell you what their gender identity is. And so it's important to keep these things in mind, that these are all separate points. And then if you do want more information about these concepts, there are a lot of great resources like this one. Of course, I'm going to put in a plug for the upcoming Primed manual as well, that talked about this and other important concepts. So this slide I put up, and I'll give you a second to look at, that outlines some gender neutral language that you may wish to use when discussing sexual health with this population and others. So the idea is that a lot of terms that we used does have a gender association with them. And so individuals may be more comfortable with some more gender neutral terms. So for instance, instead of talking about an individual's period or menstrual bleeding or menses, you may use the term monthly bleeding instead. And so there are a lot of terms that you may consider using, but it's important to identify that some clients may prefer terms such as vagina to fret hole or inside of the genitals. So I always recommend mirroring the terms that the individual uses to describe their body. And if you're ever in doubt, you can just ask. So I also want to make it clear that unfortunately at this time, there isn't a lot of data research about transmasculine individuals and related populations. It is under-researched, so unfortunately, a lot of what we know is based on anecdotal experience or sometimes extrapolated from other populations, which of course has its limitations. But I will speak about that today. And they put up this great infographic from Yeah Aware that I've also added to a little bit, just to discuss some different types of sex or sexual activities that gay, bisexual, queer plus trans men may engage in. And of course, this isn't an exhaustive list. So it's not limited to masturbation, a term that some people don't know, frottage, which is a non-penetrative sexual rubbing, generally of the genitalia, can be done with or without clothes. Kissing, fingering, cunnilingus. You may not be able to read this slide because it's really small font underneath, but that describes oral frontal or oral vaginal sex, aka mouth to the front hole or vagina. Fellatio, which is oral penile sex. Analingus, which is also called rimming, use of sex toys. Docking, which may not be a term a lot of people know. It's when the foreskin of an uncircumcised penis is stretched over another penis's head. And we'll talk about, implications of these things kind of in future slides. Fisting, the insertion of a fist into the front hole or anus, vaginal or frontal intercourse, and anal intercourse. So a lot of different topics and concepts to be aware of. And it's important, again, not to assume what an individual may be engaging in, because you don't know these things unless you know their own personal life, their anatomy, their sexual interests, really by having a conversation with them. And it's important to be aware of these various acts so that you can provide information to your clients if they do ask any questions about them. And so I'll start by talking a little bit about some ways that individuals may prepare for sex. The first is around front hole or vaginal douching. Generally involves using water or commercial product to wash the front hole. So from a medical standpoint, it is a discouraged practice, just because we know that it can increase an individual's susceptibility to certain conditions. And so I've outlined here that it can alter the pH, the acidity of the front hole, which can predispose them to a condition where there's overgrowth in the front hole, medical term being bacterial vaginosis, for those individuals maybe who have a medical background or maybe using that terminology. The chemical additives that may be in certain preparations that are available over the counter can be quite irritating to an individual. And there are some studies that suggest that there is potentially an increased susceptibility for certain infections, including HIV, various sexually transmitted infections, and a related condition called pelvic inflammatory disease, as well as ectopic pregnancy, which is a pregnancy that occurs outside of the uterus, most commonly in a fallopian tube, and can have, of course, complications associated. So for these reasons, we generally discourage individuals from performing front hole douching, but we inform them about their risks versus, of course, the perceived benefits. Another common practice is rectal douching prior to anal sex. It's a process of washing out the anus. There is conflicting research on this subject. So some research suggests that this process can increase susceptibility to hepatitis B, hepatitis C, and HIV. But the authors actually express that this finding may have other confounding behaviors or other reasons why this association might have been found in this population, such as higher likelihood that that group that was studied was using substances during sex, which is known to be associated with increased susceptibility to STIs and HIV, and that's sometimes called chemsex. Some research has found that rectal douching more than once weekly actually increase the risk of rectal gonorrhea and chlamydia. but other studies haven't found an association with rectal STIs. So it's not something that we routinely counsel individuals about. And so in the absence of good studies about it, experts recommend rectal douching no more than 2 to 3 times a week, with tap water for infrequent douching, or normal saline, which is a saltwater solution that can be prepared at home for frequent douching. And there are some good resources that discuss how much salt to put in how much water, just because you don't want the preparation to be too salty or not salty enough, because that can lead to more irritation of the rectal lining. The other thing that's mentioned is avoiding soap or other chemicals that can cause irritation and can potentially break down the lining of the rectal tissue. So that's something to be aware of. Basically, that rectal douching, there's various reports of potential increased susceptibility, but that it's not consistent. And so really more research is needed before making recommendations. And I'll start by talking about my first case now. So here, a 26-year-old non-binary individual who was assigned female at birth. And so if you see that acronym AFAB, that's what that means. Uses they, them pronouns, is thinking about starting testosterone, but is worried that it might affect their sex life. They ask you what you know about this matter. So the question is, how might you respond? So again, please use the Q&A feature in order to put some of your responses into the chat. Oh, I can't see. And then maybe once there are some responses, I'll have Eric read them out.
Actually, Dr. Jordan, it's Chris. So far, we've got one response saying increased libido, and a second one saying testosterone can increase sex drive and libido as well.
Excellent. Absolutely. Both are definitely correct. Any other thoughts about ways that testosterone might affect their sex life, and any thoughts about, you know, how it might affect their body and their organs that may be used for sex?
We've got another response saying atrophy dryness.
Yeah. Wow. Excellent. Perfect. So maybe I'll continue on because we got some great responses there, and that's absolutely correct.
Actually, just one last one here. T can change the size of the clitoris.
Absolutely. Perfect. And that's actually something that person is thinking ahead, because that's also something that we'll discuss later on as well. So there are studies that have found that there's an increased sex drive. Some studies suggest even hypersexuality in individuals when they start testosterone. So that's something that we counsel patients on, you know, from a medical standpoint before starting testosterone. But it is something that absolutely you can talk to your clients about if they are interested in pursuing this, talking to their physicians about it more. Interestingly enough, I find often in clinical practice, people often, you know, think about the doses that they're on and are quite interested in knowing whether they may get more of a certain effect with a higher dose or a lower dose. One of the things that was found in the study was that there wasn't actually a correlation between the blood levels of testosterone and sexual desire, which suggests that just being on testosterone is associated with that increased desire, but that a higher dose may not, you know, affect their sexuality, sexual drive more than a lower dose might. So that's something to keep in mind. Some studies have found that this increased sexuality may lead to a shift towards more sexual, casual sexual relationships with gay men, which tend to be more focused on just sex as an interaction and a bit more impersonal. Of course, that's not going to be, a universal effect by any means, but it is something that might be helpful for an individual to know prior to starting testosterone. It also has been linked to increased sexual satisfaction itself. But there are, unfortunately, side effects to testosterone use. So one individual pointed out the term that we use is atrophy. So that's thinning of the internal genital tissue. It has a few different terms associated, but basically it's a condition that can lead to dryness of the genital tissue, burning with urination, pain with sex, other signs of irritation such as itch as well. And it's linked to low estrogen levels. So the idea is that when an individual is given testosterone, if you think about it like a competing hormone with estrogen, that leads to a drop in estrogen and can predispose individuals to this position, to this condition. We also know that this condition can increase an individual's risk for urinary tract infections, yeast infections, and that bacterial overgrowth that I mentioned before when talking about frontal douching. So it's important just to be aware of that, but to let people know that there are treatments for it. So there are moisturizers that are designed for the front hole. If the issue is more so pain, discomfort during sex, making sure that they're using effective lubricants is important. There's also topical estrogen therapy, which some individuals may consider. There can be a concern about feminizing effects of using estrogen cream in the area, but it is very locally acting, and the amount that's absorbed into the body is quite low. So I do reassure people, if that is something that they want to try, that it generally will not interfere or interact with the effects of testosterone. So encourage them, of course, to discuss this with their healthcare provider as appropriate.
Actually, Dr. Goodrich, we've got a question. How commonly does atrophy occur when one starts testosterone?
It's a great question. There isn't, unfortunately, good literature to give us an idea of the prevalence or the likelihood. In my experience, generally individuals who are on lower doses have a relatively lower risk of this developing. So this is one of those effects that are a bit more dose dependent. The higher the dose of testosterone, the more it interferes with estrogen's effects in the bodies, can drop the levels and can lead to this effect. So basically, I just let people know it's a possibility that it's more likely at higher doses, but that it is quite treatable. Great question. Perfect. And yes, please do ask questions as we go. So I wanted to point out a resource, like I was mentioning, through Rainbow Health Ontario, guidelines for gender affirming primary care with trans and non-binary patients. So this resource was created in conjunction, Sherborne Health and Rainbow Health Ontario, and a section of these guidelines, which are posted online, focuses on testosterone therapy and actually talks about some of testosterone's effects on the bodies. So here you can see it talks about precautions, contraindications, so reasons that an individual may not safely take testosterone, some safety considerations, the formulations and their doses, and importantly, the effects and expected time course of testosterone, including some of these sexual effects, right? So here you can see, if we look down, one individual mentioned enlargement of the clitoris, absolutely. So that usually starts around the 3 to 6 month mark, but then may have its maximal effect closer to 1 to 2 years on testosterone treatment. Atrophy of the front hole, or that thinning of the tissues like discussed. So this is a great resource, and I generally provide these to my trans and non-binary clients quite often when I am counseling around testosterone use.
We just have a question here.
Yeah.
How do folks know what dose of tea that they should be taking? Is this based on body weight and dimensions?
Great question. So it's a longer conversation that the individual has with their healthcare provider. I also give presentations to healthcare providers as well. And one thing that I really try to hit home with them is the patient's goals are the number one priority and the number one, let's say, characteristic or factor that helps us to decide on the starting dose. So as you can see here, we generally have a range of starting doses, and then we titrate or we increase the dose to get the effects that an individual wants if it hasn't already been met at a lower dose. So some individuals may not want a huge amount of masculinizing features. And so, you talk to them about what characteristics are important to them. And if their goals could be met with a lower dose of testosterone, then often would start on the lower end of the range of any formulation. Whereas if an individual, here we go. If these characteristics, let's say, are all very important to the individual, and they do want a more quote unquote masculine gender expression and physical characteristics, then starting at the higher range of the starting dose, checking in to see how that dose is doing, and then increasing from there is important. So basically asking the client about their goals, but also making sure that they have realistic expectations about the timeline that this can happen. So it's okay if their starting dose isn't the dose that they end off at, because these effects can take some time. I kind of view it more as a bit more of a marathon than it is a sprint. It's an overused metaphor, but anyways, hopefully that helps.
We've actually got one more question.
Great.
What considerations do clients need to know when switching from, I apologize, deletestrel to dipot-testosterone? As you know, when one is on back order, we need to switch clients to the other.
Absolutely. Thank you for that. So for those, I know not everyone here is a prescriber, but it still is very useful, I think, for anyone who's working with this population to know. There are two injectable forms currently available for testosterone. One that the individual asked about, deletestrel, is the higher concentration one. That one's testosterone enanthate. So you'll see in this table, that first one listed, that's 200 milligrams per milliliter. The second one, dipot-testosterone, also known as testosterone cypionate, is 100 milligrams per milliliter. So it's actually quite easy to convert from one to the other, because as that individual pointed out, absolutely, like pharmacies are so commonly having one thing on back order and then the other form on back order, and switching back and forth is common. So all that's really done is either doubling or having the volume. So that way it's the same amount of testosterone in milligrams that the individual is exposed to. So for instance, if they're getting 60 milligrams weekly injections, that's 0.3 milliliters of deletestrol or 0.6 milliliters of dipot-testosterone. Perfect. Any other questions?
Actually, that's all the questions at this time.
Great. Excellent. All right. So the next case, now looking at surgical considerations when it comes to sexual health. So a year later, the same individual comes to you, lets you know that they're thinking about undergoing phallo or phalloplasty surgery, which is the creation of a penis using surgery. And they're wondering whether they'll be able to top, and if there are any potential issues of which they should be aware prior to the surgery. So again, if you could use a Q&A section to put your responses.
We've just had one response. I've heard this surgery comes with a lot of potential risks that need to be considered.
Yes, that's absolutely correct. And so we'll talk about what some of those risks are. And that's absolutely something that's integral from my standpoint as a healthcare provider when I'm counseling clients about what their options are for surgeries, not only what the perceived benefits might be for the individual, but talking a bit about these risks. So absolutely, that's an answer to that second point, the potential issues.
We've got another response.
Perfect.
An erectile device will be needed to achieve this goal.
Excellent. Great. So that's exactly right. Before I go into those answers, first I want to actually talk a little bit about the surgeries themselves and to show some pictures that may be helpful. I do want to acknowledge that, so the pictures used in this presentation are sourced from public websites, really for the sole purpose of medical education to improve the healthcare delivery to trans and non-binary individuals. But I do want to acknowledge and recognize that trans people's bodies have been inappropriately objectified and pathologized. So it's important to note that the intention here really is to improve the learning process, to cultivate knowledge, awareness, and respect, and to help the delivery of healthcare and support for this population. So here are some of the surgeries that can be considered for bottom surgery for transmasculine clients. And I want to note that when I use the term transmasculine clients, that's to mean those who are assigned female at birth, AFAB, but includes non-binary individuals, trans men, etc. So there's clitoral release, which is the least intensive of the surgeries. Sometimes it's called simple release. And so to go back to what someone identified earlier, with testosterone therapy, there's enlargement of the clitoris. And so we can actually use that to our advantage as, well, not us, I'm not a surgeon, but surgeons can, take that enlarged clitoris, cut the ligaments around it to allow it to come out of the body more, and therefore create, we use the term neophallus to mean a penis. So that is absolutely a possibility and is generally associated with the least risks or complications. The next one is called meta or metoidioplasty, but meta is really the name that you'll hear. It involves that first procedure, the clitoral release, but there is rerouting of the urethra, the P tube, through that enlarged clitoris. So it can have some benefits like allowing the individual to stand up to urinate, which can be very important to someone, particularly if you think about them using public bathrooms in public spaces. So this is a major goal for a lot of people, and meta can be used to reach that goal. One thing that I do want to talk about is with these procedures, generally, the penis is not large enough for insertive penetrative sex. So if that's an important goal to the client, these surgeries may not be the best options for them. There's also an inability to have receptive frontal sex if there's removal of that front hole, which is generally done by the surgeons here at GRS Montreal, which is a center that we often refer our clients to. They're the only ones performing these surgeries in Canada, but there are some surgeons elsewhere who may do some variations on the surgeries. So if that's performed, then they're not able to have receptive sex receptive frontal sex specifically. So that's important to be aware of. And then here is an example of an individual post-phalloplasty. This is, as someone alluded to, a lot more intensive and requires multiple surgeries, usually over the period of 1 to 2 years. So the first step, the first surgery, is that creation of the penis, usually using the skin on the forearm. And so that's why you can see in this individual that there's a bit of scarring, a very common thing after phalloplasty. There's also a scar on the thigh because skin from that thigh is actually taken and used or put on that forearm where skin was removed. So it's quite an intensive procedure in that way, and that's something you or that we counsel clients about. Usually there's also removal of the front hole during that procedure. Then they return after a period of months generally to connect the existing urethra that they have into the penile urethra. The third procedure is creation of the scrotum if desired and implants. And then there can be an erectile device that's inserted, and that would allow an individual to top, as was alluded to earlier. But there are a lot of risks, unfortunately, associated with it. And the risks change from person to person. So generally for younger, healthier non-smokers, the risk would be lower, than smokers who may be older, who may have more blood vessel disease, where there may be less blood available to go to the penis. And so as a result, less oxygen delivery, less nutrients, and the risk for tissue death is there. Studies that I've come across have found that for complete death of the penis, that actually occurs in 1% or less of individuals. And for partial tissue death, that may require more surgery. That may be closer to about 6%. But again, the risk can vary so much depending on the individual themselves. Probably most common are urinary complications. So infections, problems in terms of closing in certain parts of the urethra that may need further revisions, surgeries, or other management. But if that is something that is important to an individual, it may be desired, especially because it allows an individual to top with an erectile device in. The sensation is usually maintained after the surgery, estimated in one study to be about 3 out of 4 individuals to have complete sensation, and then, slightly decreased sensation in the majority of other individuals. There's often an increased sense of sexual arousal following gender affirmation surgery, including phallo. So it can have that beneficial effect for an individual as well. And I do want to mention that unfortunately, I wasn't able to come across any studies that looked at sexual function or satisfaction after meta. So most of these are about phallo themselves. There is also something that I came across in terms of orgasm rate. So the ability to have orgasms after one of these bottom surgeries ranged from studies from as low as 25% up to a full 100%. But it is important for individuals to know that they may feel different. Often they're rated as more powerful, shorter, and with higher intensity than before one of these bottom surgeries.
We just have a quick question, wondering how soon after surgery can someone top?
Good question. So usually, as you imagine, it actually would have to be after that 3rd or 4th surgery. That's actually an excellent question. So the surgeons themselves will, of course, give recommendations. I know that with a lot of bottom surgeries, it's kind of like a 3-month period before any sexual intercourse is recommended. And so it likely would be a period of a few months or so at least. Of course, if there's any complications, that period may be elongated. But depending on an individual's characteristics and the surgeon themselves, they may give a slightly different timeline. Great. Any other questions?
No more at this time.
Perfect. Well, continue on then. I do also want to make a brief mention of top surgery, something that actually is the most commonly pursued surgery by transmasculine individuals. It's also called masculinizing chest surgery. And there are actually a few different types of surgeries. So the one surgery, which is generally done with individuals with less chest tissue, if their anatomy allows it, is a keyhole. It's called incision, where around the nipple, a small incision is made, and then fat is removed from that incision itself. The second one, and of course, don't feel like you have to memorize these terms. This information is all out there, but it's called periareolar surgery, where 2 incisions are made, so one circle and then another larger circle. The skin and tissue in between is removed, and then that slightly larger opening is used to remove fat, and then the 2 sides are opposed or brought together. The most commonly done top surgery is called a double incision mastectomy. So that's where individuals will have larger incisions on the bottom part of the chest wall. Those incisions are where the fat tissue is taken out from. And that's generally done in individuals who may have more chest tissue or based on anatomy or other considerations. The reason I'm pointing this out or differentiating is because the first 2 procedures generally leave the nipple and the stalk in place, including the blood vessels, most of the nerves that run to it. Some of the nerves run along the skin. So each of these procedures has a bit of a different risk in terms of decreased or changed sensation after surgery, with double incision mastectomy having the highest likelihood of a change in sensation as a result from some nerves being cut in the process. Individuals tend to notice actually after top surgery that they have increased sexual satisfaction. So it is an important thing to think about when you're talking to individuals about sexual health. Oftentimes people focus more on the bottom surgeries, but we know that based on an individual's comfort with their own body, as well as with other characteristics like the nipples as potentially erogenous organs, that it can make a huge difference in terms of their sexual satisfaction. And so that sensation piece is also important to counsel them on. But unfortunately, again, we don't have great studies that give us a good idea of what the likelihood is in terms of the risk of sensation changes with one surgery versus another.
Actually, we just have a quick question in regards to the fallow surgery. Somebody is wondering about the cost for the surgery.
Great question. So these surgeries we're very fortunate in Ontario that they are covered. So basically, and I know, actually, this is probably a good thing for everyone to be aware of, whether you're, more of a medical provider or if you work with this population other ways. Individuals to get fallow surgery need to see 2 different providers who have experience in the diagnosis of gender dysphoria or gender incongruence, who have some knowledge and experience in actually counseling patients about this, potentially who have had ideally certain training. So there's training through Rainbow Health Ontario, for instance, where individuals can, who are interested, you guys, would be able to have some sessions on topics such as transition-related surgeries. So they need to see 2 providers, and then those providers send an application for funding to the Ministry of Health. And so as long as the providers have that knowledge, have that experience with trans care, there shouldn't be any issue with getting it funded. After that funding is received, then the whole referral package is sent to the surgeon.
Thank you so much. We've got another question. Can one deliver a baby after META?
It's a good question. So with how META is done, for instance, at GRS Montreal, which is the only location that does the surgery currently in Canada, they do the procedure with removal and closing of that front hole, which also involves removing of the uterus, also called hysterectomy. So because of that, individuals are not able to. Though in theory, if individuals, were to keep the internal organs and the front hole in place, then that would be a possibility. Of course, there's like a whole bunch of considerations around that. If an individual is, interested in pursuing pregnancy, we would want them to discontinue testosterone, of course. Actually, that's something that I'll talk about later. But yeah, hopefully that answers your question. All right. So I'll continue on. The next thing I want to talk about is sex and substance use, because we know in the men who have sex with men population that there is a higher use of various substances in relation to sexual activity. So it's important to be aware of this and to discuss this with your clients. A lot of information is in the primed guide about how, for instance, alcohol, marijuana, other substances may affect an individual's feelings of pleasure, how it may reduce inhibitions, some of the positive and potentially adverse effects of substances. A couple that I want to talk about specifically, first one being poppers. Because this is often something that people don't know much about or don't have much teaching about, I just wanted to discuss it very briefly. So poppers are alkyl nitrite, so a specific inhaled substance that come in this container. There are various brands available, and they're technically illegal in Canada. These substances have a few effects on the body, which is why they're used. So a brief head rush is common, dilation of blood vessels, which can lead to some lightheadedness, slightly lower blood pressure for a brief moment of time. And in some individuals, most importantly for some individuals, I should say, smooth muscle relaxation, which includes relaxing the internal anal sphincter. So this is a very common substance that's used inhaled during sex, particularly receptive anal intercourse. We know that it can irritate skin, so we recommend washing it off right away. And one of the main issues or considerations that we talk to people about is that there have been some links of chronic use of poppers with retinal damage or damage to the back of the eye. And so that can lead to visual changes. We don't, of course, have great studies. I keep saying that, but unfortunately, we don't have good, randomized trials to identify what's the likelihood that an individual who uses poppers compared to those who don't will have retinal damage. And we also don't know if there's a specific, amount of use that above which the risk is significantly higher. So it's more so just something to be aware of. And a term to be aware of is poppers. Poppers, that term can also sometimes be used to mean other things like marijuana mixed with tobacco. So it can be helpful to differentiate that with your client. The other substance that we know, particularly in Toronto, is more commonly used in the men who have sex with men population is crystal meth, often called T or Tina. And the reasons for its use are often around reducing inhibitions to allow an individual to have the types of sex that they want, and increasing intimacy or feelings thereof when using this. We know that it can also be associated with kind of insomnia because it increases someone's energy for a little bit. And so sometimes that can throw people off a little bit. There is a higher risk, unfortunately, with this substance in terms of addiction, psychosis. So that includes paranoia, for instance, particularly with chronic use, physiological effects on things like blood pressure, heart rate. So it's something to be aware of and to explore with your clients about what this substance may mean to them, and to do some harm reduction around its use. Great. Any questions about any of that?
Yes, we just received one. Is there anything specific in terms of health issues with the use of poppers or crystal to trans men from a physiological perspective versus a cisgendered male?
Great question. No. So in terms of kind of looking at things, oftentimes with transmasculine clients, we think about, might there be an interaction with testosterone, for instance? So these substances haven't been found to. So specifically to trans men, there wouldn't be separate health considerations as far as we know at this time. Great. And if you do think of questions later, of course, we'll leave some time at the end for a Q&A. The next section I want to talk about briefly is contraception. So a trans man on testosterone tells you he is having frontal sex with a cis man. They use condoms, but inconsistently. And they heard that testosterone is an effective means of birth control. How might you respond to this individual? So I'll give you guys a minute to put your responses in.
Actually, while people are putting that in, we've got another question. Can someone get testicle implants at the same time as Meta? And will insurance cover the hysterectomy? Yes, and the medioplasty.
Yes, exactly. So insurance does also cover metoidioplasty, aka Meta, and does cover the scrotum and scrotal implants as well. So absolutely, it is possible for an individual to have all of these done at the same time. In terms of the procedure, so because the Meta procedure is a bit less intensive depending on the client and the surgeon's comfort level. Of course, each surgeon is a little bit different in terms of whether they would plan to do it as a same surgery or a separate surgery. That's a good question actually with Meta and scrotal implants. My thought is because with Meta, because it involves urethral repositioning, which it can be a little bit more intensive, they likely would have a separate surgery for scrotal implants. But actually off the top of my head, I'm not sure what GRS Montreal specifically does. And if anyone has had experience with them, if you wouldn't mind maybe putting that in the chat, that could be quite helpful.
Sorry, which in the chat?
Oh, I was just saying if anyone had a response specifically to GRS Montreal and their timing of scrotal implants compared to the first stage of meta surgery, if they would do them as separate procedures.
Absolutely. So we've actually got 3 other questions or responses. Testosterone is not effective as birth control.
Perfect.
Is the first. The second response is, I would not rely on it as birth control, as birth control has low, missed, or late doses can increase the risk of pregnancy. It also does not protect against STIs and HIV. And the third one, many healthcare providers recommend a copper non-hormonal IUD, but other non-estrogen options are okay for folks on testosterone as well.
Great responses, perfect. So absolutely correct in that birth control, testosterone is not a form of contraception. So testosterone can and generally does reduce fertility, but the extent to which it does so can be quite variable. And we think it varies depending on the dose an individual's on, depending on an individual's age and other things that can affect fertility at baseline. But it's extremely important that an individual who is at risk for pregnancy and is taking testosterone is aware that it is not a form of contraception and consider the other routes of contraception. I did also want to make a note that a study has found that the most common type of condomless intercourse in the transmasculine population is receptive frontal sex. And that's probably the authors suggested that might be around a perceived lower vulnerability to HIV and STIs compared to, for instance, anal sex, where the study found there was more condom use. So barrier methods, like someone identified, really is still the go-to in terms of STI prevention. We'll talk a little bit about PrEP and other routes, of course, of HIV prevention, but it's important to consider some of these other methods. So there's, of course, the various types of condoms, including the insertive condom here, and the intrauterine device, or IUD, which is inserted into the internal organ, the uterus, to help prevent pregnancy. There are different forms. The copper IUD is one, and hormonal IUD actually is also very commonly used in a lot of my clients, transmasculine clients. So the hormonal IUD generally secretes progesterone, but it's locally acting and it's minimally absorbed into their system. So it's very safe to use in individuals who are on testosterone, and it actually may be preferred in some individuals to the copper IUD. The reason being is that the hormonal IUD, through its local effects, will thin the lining and therefore actually reduce the likelihood of an individual bleeding. So for instance, some clients who maybe want to be on lower doses of testosterone, they may want fewer quote unquote masculinizing effects. The lower doses may not suppress their monthly bleeding, and therefore thinking about some other options to do so, like the insertion of a hormonal IUD, may be an option. And so actually I'm glad that someone brought that up, because it's quite common in my own experience that clients come to me thinking that the hormonal IUD isn't an option for them or would have adverse systemic effects or effects on the rest of their body. And so doing some of that, knowledge translation can be really helpful.
We just have another question here. Dihydrotestosterone. They've heard that it's better for trans male penis growth.
It is a good question. So again, unfortunately, it's not something that has been well studied, like a lot of things, unfortunately, in trans health. So there are various forms of androgens that are available. We know that they're the two prescription forms of testosterone, but people can get other forms of androgens, anabolic steroids, online through other people that they know. So the trouble is that these other forms haven't been as well studied, and therefore we don't truly know whether it may lead to this effect more or less. There's a lot that individuals can come across online, and some of those are based on other people's experiences, but we can't necessarily extrapolate it or say from this one person's experience that it is universal, for instance, that this formulation of testosterone will lead to more of this effect than this other formulation. And we know so much of it is also related to dose and other factors as well.
Thank you very much.
Great, thank you. So the next section is on STIs, something that's, of course, not specific to the transmasculine population, but is an important thing to discuss with any of your clients. And we'll talk about what unique considerations there may be for this population. So a trans man who is on testosterone, so same person, frontal sex, cis man, inconsistent condom use. What testing might you expect this individual to receive at a health clinic? And how often might STI screening be recommended for this individual? And so again, I'll give you a minute to respond.
Okay, so we've got full screening recommended every 6 to 12 months.
Great, thank you. Any other thoughts? All right. Maybe I'll continue on then. So, of course, there are so many considerations that go into recommendations for testing and testing frequency. So you would expect them to be tested, ideally based on the types of sex that they're having. I find that some healthcare providers are a lot more up to date about knowledge about what swabs are available versus the urine and blood tests that may be offered. But ideally, if you empower your clients and inform them that depending on if they're having oral sex without condoms, anal sex, frontal sex, that their testing recommendations may be different. And in general, I like to err on the side of saying every 3 months if there have been new sexual partners in that time frame. But absolutely, it can be less frequent in individuals with fewer sexual partners, potentially who use barrier methods more regularly, keeping in mind too the context that you're working in. So we know that in Toronto, in the men who have sex with men population, syphilis rates have been rising, gonorrhea, chlamydia. So because it's higher in this population, it's often recommended to do testing more frequently. But again, it's based on, of course, the individual's own preferences and comforts and other considerations. Now, this is for screening. Of course, if an individual develops symptoms, they should seek testing and treatment through their healthcare provider sooner. And then they can also consider other health screening at the same time, like if an individual is due for a pap test. So those are some things that are kept in mind. In terms of the specific tests that are usually recommended or ordered, HIV and syphilis, we typically recommend, particularly in the men who have sex with men population. I put a note here, hepatitis testing is done generally less frequently, but can be considered for individuals who may not be immune to hepatitis A or B. Here in Ontario, men who have sex with men are eligible to have publicly funded vaccinations for Hep A and Hep B. So that's something that's helpful to know because for most populations, they may have to pay out of pocket for one of the vaccines like Twinrix, for instance, whereas these vaccines can be given separately in this population because we know that there's a higher risk. Hepatitis A and B can be transmitted sexually, such as through rimming, or the medical term being analingus. Hepatitis C is considered generally not every 3 months, but depending on an individual's risks, if they have a high vulnerability. So, we do see an association with substance use during sex or chemsex. Fisting has a higher risk for hepatitis C because of breakages in the mucosal tissue or the lining of the sex organs. And
we've got a couple of questions here.
Mm-hmm.
What additional tests, if any, do you add to a transmasculine client on PrEP or testosterone for regular monitoring every 3 months?
Great. So,
and they're wondering about testosterone levels and cholesterol.
Great. And so I'll just write these down so I make sure I don't forget all of them. So for individuals who are on PrEP, they get testing done every 3 months. And so that will include HIV, syphilis, and chlamydia and gonorrhea. Generally, hepatitis C is recommended to do once a year. But again, that's something that will be done through their healthcare provider. For individuals who are on PrEP or testosterone, we don't do any additional STI testing, but individuals who are on testosterone will have, of course, a routine measurement of their testosterone levels and other levels that may be affected by testosterone use.
Excellent, thank you. And then the other question is, Hep C a higher risk for trans clients suffering from vaginal/frontal atrophy? Does dryness create a risk for bleeding?
Excellent question. We believe it does. Unfortunately, I'm going to use the line of we don't know because we don't have research, but absolutely from what we know about hepatitis C transmission through sex, we know it's low risk for, that individuals have low vulnerability, in other types of sex, so oral sex, frontal sex for individuals who aren't on testosterone. We know the risk or the vulnerability is lower, but we do believe in individuals who may have, atrophy or thinning of those frontal tissues. They're at higher risk for that irritation and breakages, and so they may be at higher hepatitis C risk. So that's absolutely something that they should talk to their physician about. But again, ideally, if those individuals, who do have these findings, these changes in their vaginal tissues or frontal tissues, if they are seeking, help from the healthcare provider, ideally they'll help treatment for these underlying conditions, and therefore their vulnerability will decrease. And your question about cholesterol levels. So testosterone has been in some studies associated with high cholesterol levels, which is why it is actually routinely measured at baseline, and then typically at the 1-year mark after being on testosterone therapy, and then as needed afterwards.
Excellent, thank you. And another question has come in. Would you do empirical CG/CT treatment for a trans man who has sex with cis gay men and has had confirmed exposure? Apparently, empirical CG/CT treatment for cis women who have sex with cis men is not recommended.
Good question. It's very dependent. So it's something that I offer, yes. But it's dependent on the individual and their preferences. So I'll have some clients who maybe has been exposed to gonorrhea or chlamydia, their sexual partner has contacted them to let them know. Whether or not they're having symptoms, some individuals will want to be treated right then and there. And that's absolutely reasonable to do. It's not mandatory. So some individuals who you know very well, or you're able to follow up with easily, you may actually just do testing and then treat only if positive.
Excellent, thank you. And another question has come in. HIV medications that lower your chances of transmitting HIV and testosterone. Can you take testosterone at the same time? What are the effects for trans men taking those medications?
Yes, absolutely. So we know that luckily testosterone does not interfere or interact with HIV medications, and that includes PrEP. So luckily they can take it without any dose adjustments needed. Great. And maybe for time's sake, I'll continue on just to show you that there are different swabs that are available and should be considered in this population. Throat swabs for oral sex without a condom, rectal swabs for receptive anal sex, and then there are also frontal swabs that can be done instead of the urine, but depending on a patient's preference and whether or not they have symptoms. And I just want to really quickly say that some STIs are not routinely tested for. So herpes, human papillomavirus or HPV, molluscum, crabs, which is sometimes called pubic lice, but may arise in other locations than just the pubic area. These are things that are generally diagnosed when there's symptoms. Sometimes we can do swabs of lesions or biopsies, but they're not usually tested routinely. So sometimes, people are under the impression, oh, I'd like to get my full STI testing, that it would include all of these. And I also want to make a note that many of these can be passed from skin-to-skin contact. So we talked about some sexual practices, even like frottage or sexual rubbing, docking, of course, oral sex, etc., can pass some of these infections such as herpes or HPV. We don't know, for instance, for frottage, what the percentage likelihood of transmission is. Those studies haven't been done. And we know that barrier methods can help reduce the risk of transmission, but they're not always able to prevent transmission fully. So it's important to just be aware of that and to counsel people accordingly. And here, of course, are some pictures of some preventative means, some barrier options, and some of which we've already talked about.
We've just got another very quick question here.
Yeah.
Considering what you said about substance use being higher in this population, do you believe there is a higher sexual risk taking behavior, and therefore do you recommend PrEP to those clients who may be using poppers, amphetamines, or anything else?
Great question, and something that I will shortly get to. Actually, that's a great primer for this section. So now we'll talk a little bit about HIV. A trans man on testosterone tells you he's having frontal sex with a cis man. So again, same individual as before. Last frontal intercourse without a condom was 1 month ago. Planning to get a standard HIV blood test today. Wondering whether their results would be accurate. So again, most recent exposure without a condom or potential exposure a month ago. What would you expect the likelihood is that the test will pick it up? And they're also wondering how they can lower their vulnerability of acquiring HIV in the future. And so maybe for time's sake, I'll make a note here. We know that with the point of care tests, also known as the rapid tests, which are offered in a number of different settings, they detect the antibody in the blood, which can sometimes take up to 3 months to come up. So for this individual who had sex without a condom a month ago, if there was transmission at that time, it might not be picked up. Whereas we know that with the 4th generation test, which is the blood test that is now available through labs, the window period is shorter because it also detects another thing in the blood that can be used to pick up HIV at an earlier point. So the window period, which here I'm using to say 99% likelihood of picking up HIV, is actually 1.5 months. And the likelihood of picking up HIV at about 1 month is close to 95%. So it's a pretty good test. And in an individual who is more anxious, you may recommend that blood test through the vein rather than the point of care or rapid test. And then in terms of options for HIV prevention, it's important to keep in mind, of course, there are structural approaches. So looking at a community-wide approach, advocacy approach, environmental, reducing discrimination, behavioral approaches. So looking at the patient's behavior, their provider's behavior, about speaking about sexual health and counseling, and then biomedical approaches. Barrier methods, treatment of STIs reduces the likelihood of HIV transmission, circumcision, which is something that is sometimes used in other countries, not commonly in Canada, to help reduce HIV transmission risk. Treatment of prevention, as prevention, HIV PrEP and PEP, which I'll talk about. And so just a very brief, because again, PrEP could be an entire lecture on itself. Currently, PrEP is 1 pill taken daily, and for the most part, the most common form being Truvada, which now has a generic form available. So there's 2 drugs that would act against HIV in Truvada. Individuals start taking Truvada prior to their higher vulnerability or higher risk periods, would continue throughout, and generally is used in combination with recommendations for quote unquote safer sex practices. The one main difference I want to make here for our transmasculine clients who are engaging in frontal sex is that to get to protective tissues in the front hole, studies have found that it takes 20 days to do so. So for cis men who have sex with men, who may be having anal intercourse, and for transmasculine clients who are exclusively, having non-frontal intercourse, within 2 to 7 days, levels are high and protective enough that they're actually okay. But in individuals, again, engaging in frontal intercourse, the main difference is that it takes 20 days, we believe, to get to protective levels. So you want to, counsel them accordingly. The other thing is that in this population, the on-demand, sometimes called 2-1-1 method of prescribing PrEP, immediately before, so 2 to 24 hours before sex, 1 pill 24 hours after, and then another pill 24 hours after that. That practice is not recommended, again, in transmasculine clients who are engaging in receptive frontal sex. And so here, really quickly to point out, who would you maybe recommend considering PrEP in a bit more strongly? So guidelines recommend men who have sex with men, of course, who we're talking about today, trans women, who have another factor. So a recent bacterial STI, a high number of sexual partners, who are doing commercial sex work, who have inconsistent or no condom use, and or who live in an area of high prevalence for HIV. Previously, also was recommended for serodiscordant couples, but more and more now, as we know that undetectable equals untransmittable, if the individual living with HIV is on treatment, taking it daily, and is undetectable, we're not worried about transmission, so we actually wouldn't routinely recommend PrEP in the individual who's living without HIV. People who do inject drugs or share drug use paraphernalia are also at higher vulnerability for HIV, and so we'd recommend it in that population. And I want to just quickly say that PrEP, a lot of people are quite worried about their effects. Their short-term effects are common side effects that we see with any medication that typically go away with continued use, though not always. And the long-term effects we generally worry about less in most individuals in this population. They tend to be younger and quite healthy, so the risks of decreased bone density isn't as significant in those who aren't at high risk of breaking of bones, right? We'd worry more in our older populations or those who have other risk factors. And you may consider recommending calcium and vitamin D. There's not a strong recommendation to do so as long as an individual is getting adequate levels in their diet. Kidney function is also tested every 3 to 6 months because it can be associated with a decreased kidney function. The likelihood that it does so to a significant extent is quite rare. And the good part is, if there is any change, we see that on discontinuing PrEP, levels come back to normal, both in terms of bone density as well as kidney function levels. And then the other consideration is for PEP. And so this is using antiretroviral medication after a potential HIV exposure. Again, this is started within 72 hours, continues for 28 days, and is most easily accessed through the emergency department. So if for some reason an individual is worried about their HIV risk, let's say they had an unprotected exposure for someone whose HIV status may be unknown, this is absolutely an option for this population. Yeah, and lastly, I just want to say PrEP and PEP are always the individual's decision of whether or not they want to take it. Some individuals have said that unfortunately they felt almost coerced to take these medications, and it's completely up to this person about what they put in their body. It is one of many preventive tools that we have at our disposal. And U equals U, I put up here as well, but I've already discussed about how that's really something that we strongly, we push, we let our population know about. And it's really important because we are working hard to reduce the stigma that is associated with HIV. We know that reducing stigma is associated with increased testing, increasing people being on treatment. And so there are such big benefits to standing behind this principle of undetectable equals untransmittable, and to counsel and to teach our clients accordingly. So the PDF of these slides will be sent out. They have a lot of different resources that are available. Of course, Primed is one that I'm plugging. Some of these I've already talked about, like through Rainbow Health Ontario. I want to say that unfortunately, some of these websites, these resources aren't explicitly trans-inclusive, so they may not use necessarily trans-inclusive language. And so it is important to counsel individuals about that before sharing some of these resources. Great. So thank you everyone for attending. At this point, I'll take any lingering questions.
Excellent, thank you.
Assuming this time.
Yeah, we've got 3 minutes and 7 questions.
All right, let's do that. And any that I'm not able to answer, I think we've talked about that I can type out an answer and that can be sent out with the slides.
Absolutely, thank you. And I sent that out in the group chat so people are aware. So the first question is, we don't know the percentage likelihood of transmission for chlamydia, gonorrhea, or syphilis with and without barriers for various forms of sex, either, do we?
Exactly, no. So, and it's a great question. It's something that I've scoured the literature to try to find. You know, people have said that, like, so you're exactly right. We have difficulty estimating the likelihood, especially because we only test people every few months or often less frequently. We don't know necessarily when it was picked up. An individual may have had multiple sexual partners, multiple types of sex. So you're exactly right to say for one episode of bottoming or receptive anal intercourse, the risk of chlamydia transmission is blank. We don't have great numbers to say so. And we know that there's so many factors that can affect the likelihood of transmission.
Thank you very much. So this was a question in regards to the HIV testing. Somebody is asking if the P24 antigen test should be used.
Great. And so that's actually, one step ahead. So the 4th generation test, that's the difference. So the 3rd generation test, aka the blood test that was done through the vein, but that was available, like 10 years ago, that one only tested for the antibody, similar to the point of care test or the rapid test. The 4th generation blood test tests for the antibody to HIV and automatically tests for that P24 antigen. And that's the reason it's better able to pick up HIV early. Great question.
Excellent, thank you very much. I'll hand things over to Eric, and any unanswered questions will be responded to with the PDF slides as well as the link to the video. Okay, we seem to be having an issue with Eric's audio. We apologize for that. And
sorry,
oh, there we go.
Sorry about that. Thanks again, Dr. Goodrich. Thanks everyone for attending today's webinar. I truly appreciate that. I hope that there are many takeaways that'll be useful to you and your work, in addition to gaining a better understanding and perspective of not only the sexual health of transmasculine individuals, but also some of the valuable tips to consider regarding harm reduction approaches, the recommendations around STBBIs and testing, the impact of testosterone, and their sexual health. Please keep in mind that there'll be a circulation link to the recording of today's presentation and as well an evaluation. Please use that as an opportunity to provide feedback that will help to inform our work and future webinars. We also ask you to keep in mind about the upcoming virtual Prime launch. And again, thank you again, Dr. Goodrich, for that insightful and amazing presentation. It was exceedingly great. Thanks. Thanks everyone. Do have yourself a great day, and thanks. Bye for now.
Thank you so much again, everyone.